tibiofemoral joint, the anterior cruciate ligament, the posterior cruciate ligament, and the lateral collateral ligament and the medial collateral ligament are designed to keep the femur, tibia, and fibula from sliding out of place during general movement. The ACL originates from the anterior medial aspect of the tibial plateau and runs superiorly to the lateral femoral condyle, whilst the PCL originates in the posterior intercondyle area and travels anterior superior to attach to the medial femoral condyle. The MCL attaches to the medial epicondyle of the femur and terminates with the medial condyle of the tibia, whilst the LCL originates at the lateral epicondyle of the femur and its insertion point is at the fibular head. Each is made of a band of dense, regular collagenous fibres with low vascular content. These structures are extremely important to the integrity of the knee, especially during high-impact activities, as they prevent hyperextension and guide the instantaneous centre of rotation for the knee.
Radiologists have a variety of imaging modalities at their disposal to view an ACL in a patient. However, some are more appropriate than others. Take a plain radiograph, for example. The semi-radiopaque and superimposed model we see instead of seeing our ACL is due to the limited range of absorption of soft tissues as the X-ray beam passes through them, making it near impossible to identify specific structures, thus unideal for viewing our ACL, save for perhaps identifying an aversion fracture, which may indicate an ACL injury. A CT scan, however, shows more promise. With the now wider absorbance spectrum and elimination of superimposing, we can now see the ACL as a semi-radiopaque band. However, the tissue is still difficult to identify, and in the event of hemoarthrosis, which is fairly common in ACL injury, visibility becomes greatly impaired. An MRI scan is the best modality for viewing our ACL. By creating an image based on the number of hydrogen atoms in a tissue instead of ionizing radiation like the last two, an MRI is perfect for viewing specific soft tissue structures, thus the best modality for viewing our ACL.
Thanks, Joseph. Now, as we've discussed before, ligaments have a low to void signal intensity. Now, if we look to my left here, we got 3 MRI images here. The first one is a T2 weighted MRI, the second one is a T1 weighted MRI, and this is a coronal T2 weighted MRI. Now, there are multiple ways to tell if a ligament has been ruptured. The first being a wavy and discontinuation of fibres within a blurred appearance on any weighted MRI. We can see mainly here in the T2 weighted MRI in row 3 and 4 that it is also further confirmed here in the T1 weighted MRI. This then also gives a higher rise to the PCL, making the PCL more defined and also have a more superior curve. As you then can also note, there is no crossing over from the PCL to the ACL. This is then further confirmed within the coronal image of the interjoint space within the knee, where there is no void-like structures where an ACL should be until we get to the image of the PCL.
We're now aware of the characteristics of a tear in the anterior cruciate ligament. Despite MRI having a reported 93% accuracy for diagnosing an anterior cruciate ligament tear, it is possible for tears of the anterior cruciate ligament to be misdiagnosed. Mucoid degeneration of the anterior cruciate ligament is commonly misdiagnosed as a tear in patients who present with similar symptoms of a torn anterior cruciate ligament. Upon imaging the mucoid degeneration, it is found to have a thicker appearance, often being described as a celery stalk, and will appear with high signal intensity on a T2 weighted MRI. These radiographic appearances are similar to that of a tear in the anterior cruciate ligament. To effectively differentiate the diagnosis, T2 weighted MRIs of the anterior cruciate ligament should be investigated for fibre discontinuity,